Despite psychotropic drugs that have been used for such a long time, and sometimes we just don't really understand how some of these drugs improve psychiatric symptoms. So in this chapter, we're going to focus on those medications. How do they work on the brain to increase or decrease those neurotransmitter behaviors? So let's get started here. So let's look first at the structure and the function of our brain. We can think about are the neurons. And once an electrical pulse reaches the end of a neurotransmitter is released. That neurotransmitter is a chemical substance that functions as a neuromessenger. Neurotransmitters are released from the axon terminal at the presynaptic neuron on excitation. The neurotransmitter then crosses the space or the synapse to an adjacent postsynaptic neuron where it attaches to receptors on the neuron surface. After attaching to a receptor and exerting its influence on the postsynaptic cell, the neurotransmitter separates from the receptor and is either destroyed by enzymes or it's taken back into the presynaptic cell from which it was originally released by a process called reuptake. These neurotransmitters are either used or destroyed by intracellular enzymes. So as we really focus in on those different neurotransmitters, alterations of any of these chemicals is the basis of our psychiatric disorders and is the target for pharmacological treatment. So when we think about dopamine, this is an excitatory neurotransmitter that is responsible for transmitting information about emotional responses, complex movements, and cognition. So it is really responsible for an individual experiencing pleasure and reward from behaviors, and its neurotransmission can be affected by stress. Serotonin is an inhibitory neurotransmitter that is responsible for emotional regulations, sexual behaviors, temperature regulation, sleep, and pain management. Norepinephrine is an excitatory neurotransmitter responsible for learning, sleep, mood, memory, and attention. It is the most common neurotransmitter in the nervous system and is a derivative of epinephrine, which again is another excitatory neurotransmitter that is responsible for our responses to stress. Histamine has a unique role in neuromodulation. The pre- and postsynaptic receptors for histamine regulate that release of histamine, glutamate, serotonin, and GABA. The known postsynaptic receptor for histamine in the brain mediates the effects of alertness and wakefulness. GABA is an amino acid that serves as an inhibitory neurotransmitter, and it's similar to histamine. Medications such as benzos aim to enhance the binding of GABA to its associated receptor, thereby reducing those manifestations of anxiety and inducing sleep. Glutamate is an amino acid that serves as an excitatory neurotransmitter. And the last one, acetylcholine, is a neurotransmitter that has both inhibitory and excitatory properties. When these receptors are found throughout the body, particularly in the skeletal muscles system. Acetylcholine helps regulate the sleep-wake cycle and is the primary neurotransmitter for muscle functioning. So let's get into our drug classifications. So the first one we're going to look at is our anxiolytics, or our anti-anxiety medications. So the drug class exemplars are our benzodiazepines and buspirone. Benzos is the most prescribed medication for treating anxiety. It is the most commonly used medication, or some of the most commonly used medications are alprazolam, chlordiazepoxide, diazepam, and lorazepam. Buspirone is commonly used medication as well. If our benzos aren't working, then we may need to go to the buspirone to help treat anxiety. Some adverse effects that we can think about with these medications, with benzos, manifestations are typically related to inhibitory responses. They can be related to central nervous system, depression, sedation, poor concentration, impaired memory, and even drowsiness, which may put our patients at risk for falls. We do have to be mindful that you can have benzodiazepine toxicity. And so if you're, there are some medications that would help if we are in a toxic, if we have toxic effects going on. As far as adverse effects with buspirone, it acts on the serotonin receptor, causing things like sedation, nausea, headaches, and dizziness. So what are we going to teach our patients? We're going to teach our patients that these medications are only treating the manifestation of anxiety and not causing the anxiety. So benzos potentiate the effects of, will potentiate the effects of alcohol. And so the two of those should not be consumed at the same time. So really teaching that alcohol has to be off limits. There is a sedating effect that can disrupt activities. So we need to make sure we're planning when they take those benzos at an appropriate time. We never want to abruptly discontinue benzos, so we have to put those on a tapering type dosing. Antidepressant drugs is the next classification we can talk about. And you can see the drug classes are MAOIs, or your monoamine oxidase inhibitors. The tricyclic antidepressants are your TCAs. Selective serotonin reuptake inhibitors are SSRIs. And serotonin norepinephrine reuptake inhibitors are your SNRIs. Other medications such as trazodone, methadone, bupropion, and mirtazapine are other medications that are considered antidepressant drugs. Some of the therapeutic use and mechanism of actions therapeutic uses for depression and anxiety. The DSM-5 identifies various disorders that present with manifestations of depression and anxiety, such as major depressive disorder, bipolar disorder, generalized anxiety disorder, and post-traumatic stress disorder. Your MAOIs are a type of antidepressant where the mechanism of action inhibits the function of the enzyme monoamine oxidase. Your TCAs is also an antidepressant, which affects the serotonin and the norepinephrine by blocking their reuptake into that presynaptic receptor. Your SSRIs, mechanism of action affects serotonin by selectively blocking the reuptake on the presynaptic receptor. Your SNRIs affect serotonin and norepinephrine, again, by blocking that reuptake. Some of the adverse effects that we can think about with our MAOIs, weight gain, daytime sedation, sexual dysfunction, and insomnia are really big adverse effects. And I think what we really have to remember with the adverse effects is if our patients are going to experience some of these adverse effects, what are they going to do? They're going to stop taking their medications. So we need to talk to them about here are some of the adverse effects. And then if they're like, no, if my sexual dysfunction goes down, I am going to stop taking these meds. So we may have to find just something different from the get-go. Our TCAs can block cholinergic receptors, resulting in some anticholinergic effects like dry mouth and constipation. So we need to make sure we're just making sure that patients are aware of that. With our SSRIs, nausea, agitation, sexual dysfunction again. SNRIs are very similar to our SSRIs, except that it can include appetite suppression as well. So anyone beginning or increasing the dose of any antidepressant really needs to be watched closely for any worsening depression or unusual behavior, including increased risk for suicide. So what are some of the things that we can teach our patients? It may take a few weeks to experience relief of clinical manifestations when we begin treatment. So for example, our SSRIs may take 4 to 6 weeks. The TCAs may take 2 to 4 weeks. So remember, our patients are depressed. Is 2 to 4 weeks an ample amount of time to wait? Or is their depression going to get worse in the meantime? With our MAOIs, we have to really teach our patients about diet. If they are taking MAOIs, they cannot eat foods that contain tyramine, which just increases the risk for an for a hypertensive crisis, which I'm going to talk about here shortly. Oh, maybe right now. So foods high in tyramine should be avoided with clients on MAOIs. So these are foods that are aged or fermented, and they have high levels of tyramine. Some foods that are high in tyramine should be avoided are smoked meats, red wines, beer, aged cheeses, chocolate, avocado, and soy products like tofu. Antipsychotics are neuroleptics. When we think about these drugs, they are used to treat a variety of manifestations that typically present in schizophrenia spectrum and other psychotic-related disorders. There are two generations of antipsychotic drugs. The first and the second are the one we're going to discuss. When we think about our first generation antipsychotics, they work by blocking the dopamine receptors. It's a very potent dopamine antagonist and can be effective by treating severe manifestations of schizophrenia. The potency also causes some concerning side effects. Commonly used first generation antipsychotics are haloperidol, fluphenazine, clozapine, and chlorpromazine. Second generation antipsychotics work by blocking dopamine receptors to a lesser degree by inhibiting the reuptake of serotonin. So this is going to lead just to a different profile for treatment and manifestations like the positive and negative clinical symptoms we see with schizophrenia. So although it's not as potent as first generation, the second generations do have a lesser degree of severity and side effects. Some of the most common side effects are anticholinergic manifestations, such as dry mouth, constipation, blurred vision, and orthostatic hypotension. What are we going to teach our patients? We need to just make sure they understand the necessity to continue the treatment even after the manifestations resolve. Clients may feel some side effects and they are intolerable, so the nurse should just really encourage the client to speak to their healthcare provider about any alternative medications. Mood stabilizers are used to help relieve manifestation of mood dysregulation found in disorders like bipolar. So some of the therapeutic use and mechanism of action, when we think about lithium, this remains a point of controversy in its efficacy when compared with other mood stabilizers, such as valproic acid, which is our anticonvulsant. Lithium has effects on regulating the reuptake of monoamine neurotransmitters, and it is the primary medication used to treat mood dysregulations. So when we think about lithium therapy, when we're initiating lithium, blood testing to monitor the level of lithium should be performed every 1 week or 2 weeks, depending on therapeutic level. The healthcare provider will order a serum lithium level to determine if the client is in that therapeutic range. Lithium is a medication that we have to be very intentional with as far as making sure it's in the therapeutic range. Lithium toxicity can be very concerning, and I think I'm going to get to that here shortly. So lithium toxicity include dehydration, overdose, and concurrent use with loop diuretics. Some of the common causes are lithium levels greater than 1.5, early toxicity, serum levels are greater than 1.5 milliequivalents per liter. Some of the clinical manifestation can be poor coordination, confusion, sedation. They can also have GI discomfort such as nausea, some coarse tremors, vomiting, and diarrhea. So what do? We need to withhold that lithium treatment and make sure the healthcare provider is aware. As they advance with toxicity, then our serum levels are 2.0 to 2.5. Now clinical or Psychological manifestations can be seizures, stupor, diluted urine, blurred vision, respiratory complications, tinnitus, jerking motor movements. So as they advance, the clinical manifestations definitely get worse. So what do we need to do? We need to get that out of their system. So we'll usually administer urea or mannitol to try to get it excreted from the kidneys. Severe toxicity is any serum lithium level greater than 2.5, and these patients are going to deteriorate rapidly to a comatose state. Risk of severe respiratory complications that can lead to death. So we must consult the healthcare provider to initiate hemodialysis. Anticonvulsants is the other drug class that we can think about. So if lithium is not well tolerated, then we can switch to our anticonvulsants, such as Tegretol, Depakote. They help treat those mood dysregulations. Some of the common side effects, again, may be dry mouth. Depending on the anticonvulsant formula, they may see weight gain with our valproic acids or weight loss with our toprimate or lamotadine. As far as teaching, we need to emphasize non-pharmacological interventions to help reduce stress. Despite that they may be getting medications, a relapse of manifestation is still possible if they experience unmanageable physical and psychological stress. And that concludes the chapter. If you have any questions on this information, please shoot me an email or we can chat about it in class. Thanks, guys.